It's 5 o'clock. I'd like to welcome all you hardy souls that made it here, okay, through this pouring rain and lightning and everything that we have. And anybody who is on the television, welcome. This is our regular monthly meeting of the Indian River County Hospital District. And to start the meeting, we would like to invite Father Chris Rodriguez up to give the invocation.
Thank you very much.
Welcome.
Ladies and gentlemen, my name is Father Chris Rodriguez. I'm the rector of Trinity Episcopal Church here at Vero Beach. It's a pleasure to be here tonight with you all, and thank you, Tracy, for the invitation. Appreciate that. Shall we pray? The Lord be with you. Let us pray. Lord God, we thank you for this day you've given to us. We thank you, Lord, for Vero Beach, for this community, for this county. We pray, God, for your blessing upon us and upon our work here and for the people that live here. Father, we pray for the grace and presence of your Holy Spirit tonight to give us wisdom and the spirit of service and joy in all that we do. In Jesus' name we pray. Amen.
Amen.
Thank you.
Thank you so much. Dr. Weiss?
Join us. Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. Okay, we will proceed with the consent agenda. I would like a motion for the approval of the chairman's meeting minutes dated June 20th, the regular monthly meeting minutes dated June 21st, and a July disbursement of, Mr. Jones?
$1,352,921.41.
So moved. Second.
Okay, all in favor?
Aye.
Okay. A couple things that I wanted to report is this morning we had our chairman's meeting. We had a discussion relative to the hospital's request to be able to do a copay for the indigent, for non-emergent visits there. There was a request by Tracy Zudans to maybe get another opinion relative to whether the district is legally allowed to do that or not. Our outside counsel has been contacted. They were not ready to be able to give an opinion today. They would like to do some research on it if possible. But because this is outside the scope of what they have been retained for, which is for the partnership process, they will be charging us extra to be able to do that research in order to be able to support or not be able to give an opinion on that subject. So I wanted to be able to come back to the group and say, do you support spending the money to be able to get a second opinion on that? And if so, then we will just have that opinion for next month. And if you feel comfortable, if the trustees feel comfortable moving forward with the opinion of our own in-house counsel, then we will talk about it later and on unfinished business.
Did they give you an idea of the cost?
They figured that they would, I don't, but it would be under their regular fees.
But I mean, how many hours does it take to find out?
They did not give me an idea on
I
that.
think it's an hourly rate.
It's an hourly rate.
However, if I may say, we have counsel. I trust our counsel. We have our counsel for a reason. She's done a wonderful job. She's never brought us or guided us the wrong way. I myself am okay with going with what our counsel has said.
I think Tracy's question was about all the commas that
Well,
didn't quite.
I don't think that the summary or interpretation that we were given really explained it well enough. I didn't agree with it because I think that indigent patients are not financially able to pay, and I think there's a differentiation between the two. So I'm not in agreement with the summary, and I would feel very, very uncomfortable, and I would not vote for us to go ahead with the copay just based on that summary.
Well,
And it's not that I'm against the copay, please don't get me wrong. I am for that, but I want to make sure that we are legally allowed to do it.
can we ask for an Attorney General's opinion?
Oh, that's a lot of money and.
That would cost us
Not
money? I thought that's not
necessary.
necessary.
I don't think it costs money to ask
I
the
don't think
Attorney
s-
General about
I don't
that
think there's a
opinion.
cost involved with that.
There is another perspective, I guess, that I'd like to throw out there, which is that as I read our documents, in this particular case, it's not the district that is requesting a copay. It is,
Hospital.
it's the hospital that is requesting a copay. Much the same as Treasure Coast requests a copay, and much the same as actually the health department, if in fact somebody doesn't give their paperwork for the second time, they request a copay too.
Very good point.
And we still
Very good point.
reimburse them, okay?
So maybe they do the research and pay for it.
Well, I don't know that it's even a legal question for
No, it's
us,
not.
because since
Okay.
it is not us, I think it
Right.
is just a matter of whether we support or don't support the position that the hospital has taken. That is my opinion on that.
Wow, that's interesting. Oh, that's a good point.
It's not us that is charging people, it is the hospital that's charging. I think they have every right to do that. We will still reimburse them for our piece of it, just like we reimburse the other one. So I think it's a matter of a change of policy from the hospital, and they are asking our approval to change their policy.
Well, perhaps they should put together the exact wording of the policy and present it to us, and then we can vote on the exact, and on that as, you know.
I would be more comfortable with that than,
Yeah,
voting on the copay tonight based on.
yeah,
just
because it really isn't our copay.
It is
It's
not our
theirs.
copay, it's-
So I think that's great. Mary Beth, good thinking,
No, it's a very good point.
whatever.
I guess I look at it a little differently. I look at it that the hospital belongs to the residents of the county ultimately, and it's a special act that enabled us to build and construct the hospital and raise the money through debt. I think if one of the trustees has a serious concern, the fact that we get another opinion doesn't bother me. It can't cost more than a relatively small amount of money, and we haven't had these co-pays for decades. So if we wait another couple of weeks to be safe, I'm okay with that. So I would support the concept of getting even a second opinion. That's not a reflection on Jennifer Pesky's opinion.
And it may support her opinion as well, I would just feel.
I expect it will. I think, I mean, I've done some research on this topic and come to the conclusion that I think we have the authority to do that. But if there's any question, I think it should be satisfied. I don't think it's prohibitive expense or time delay to do it. So I would support that concept.
Well, then I think they should put together a formal request for the copay, and concurrently, I would agree with you to go ahead and get a second opinion and see if it's, you know, so they could put it in, we'll be working at the same time, so we would have an answer one way or the other.
So I would request two things, I guess. I would request that they give us a formal opinion on whether we, the district, can charge a copay, but also whether, in this particular case, it applies as we are requesting a copay. Does that satisfy your
I mean,
question?
I view it as the taxpayers or the residents' hospital at the end of the day. And those are the only reasons that we would have any restriction. So I don't see, if it delays it a couple weeks, that it is major. And if we find out there's a problem, we're going to be glad we did this. So I endorse the suggestion. So, however, I will go on record to say I'm going to vote for the concept unless it's illegal, because I think it is a smart idea on the part of the hospital.
I agree, as long as it's legal, I would also support it.
Okay, so it's really a twofold kind of thing. It's A, is this even a district issue? And B, if it is, then do we have the authority to do that? And we will ask them to do that and get us a formal.
Yes, wouldn't we also then have to change our agreement with the hospital on our reimbursement that we allow them to do this?
No, we wouldn't have
We don't
to
have to
change
make
our
a change
agreement
in
with the
our
hospital,
agr-
but we would have to put some language into our policy and procedure manual and into our rules and regulations, if you will, of how we
Yeah.
reimburse that and cover that with our organizations. And we would obviously do that part and parcel with the policy that the hospital, process that the hospital develops. So, we'll get the
So we'll work on that
opinions,
over the
and
next couple
then
weeks, and we'll get an
in
opinion,
the
and we
August,
will get,
chairman's or regular meeting, we'll
Okay.
bring
Policy.
all of it together as a
Policy changes
package.
done.
Okay.
Okay,
This will give us time to do both.
okay. In that case, we will not discuss it in unfinished business tonight, and we will not have a vote.
to add
tonight.
that on.
Okay,
Oh, we have to take a vote about the attorney, the second opinion. Don't we have to vote on that?
I think everybody agreed that they would like to get,
No, I understand that, but don't we have to have a formal vote on authorizing the trade to spend them,
Could put an
get the second opinion?
amount on.
I don't know
that you
what
would
the
go to,
amount
but-
would be, but
yeah, I think we need to get an amount of what they were charged and that type of thing. We can take a vote if you like, if you're more comfortable
Sure,
with
I'm
that.
more comfortable.
So
with
may I
it.
hear a motion to get a formal second opinion?
So move.
Second,
Okay, all in favor?
Aye.
Aye.
Any next? Okay, we will move forward on that. Thank you. The only other thing that I did want to give just a very short update on the partnership process, which is still moving forward. Cleveland Clinic is just about, I think, completed, and Karen, you can reinforce that, but their due diligence at the hospital. There was a few more items that were updated. There's a few more things from a district perspective that they're still learning about and getting in, but it is still moving forward, and we are still hoping that through the month of August that we will have agreements to review and make public and to be able to go through. So that's really all the update that we have on that today. District Council Jennifer is on vacation, so she has a written, do you want to read that? Or it's in our packet.
it's in your.
It's in our packet, so we'll go through that. So we'll move right on to the financial statement. Alan Jones?
Okay, thank you. As you might expect, the district's finances remain sound. However, as noted in previous reports, there'll be little excess at the end of our year beyond our reserves. The reserves, though, will be sufficient to manage through the beginning of the next fiscal year until tax revenues begin to flow again. As of June 30th, our bank balances totaled a little over $7.6 million, though we just approved the expenditure of almost $1.4 million. So that's going to take our balance to about $6.2 million, with July, August, and September expenses yet to come. According to our budget, we project about $4.5 million left to distribute, leaving somewhat over $1.7 million in deposits at the bank. Since the reserves we maintain total a little over $2.2 million, this means we'll be invading our reserves a little by a little less than $500,000 at fiscal year end, assuming we spend all the money as budgeted. And that's okay, because that's why we have the reserves. It's important to note that the figures outlined include reimbursing IRMC about $1.2 million for the amount their indigent volumes have swelled beyond the amount we budgeted. We will have enough money to do that if we choose, as we've always done in the past. With no tax revenues coming in during October or even early November, we will likely draw down reserves further during the October expenditure period. This is the first time since I've been treasurer these reserves have actually been used, but that's exactly why we decided 3 years ago to maintain them. This year's result reflects two things. One, that the current fiscal year's budget minimized the millage rate on behalf of taxpayers because we carried over little excess cash, as little excess cash as possible coming into the current fiscal year. And secondly, the significant increase in indigent volumes at IRMC My opinion is the principal cause of that volume increase is that fewer low-income residents are being covered by the Affordable Care Act. We can debate this and even debate why this is so, but it is what it is. On balance, though, the district has sufficient funds to fully fund all of our obligations through November when new revenues will replenish our balances. So that concludes the treasurer's report, unless anybody's got any questions.
Any questions for Alan? As always, very well done and very well explained. Thank you.
Thank you.
Our executive director report, Anne Marie.
I also have submitted my written report. I think I covered everything in there that has been ongoing and what we've been working on. Been heavily involved in this budget presentation, the ER copay discussions, and some other findings of the organizations answering your questions from our last meeting in order for us to approve a budget tonight. So I don't really have anything in addition unless anybody has any questions for me. None?
Thank you. And again, I'd like to say congratulations on finishing your Indian River Leadership Program.
Right.
We're all very happy for that. So we'll get right into the funded agency reports, and the VNA is up first. Kathy Orton.
Good afternoon. Thank you for having me here today. Madam Chair, esteemed trustees, my name is Kathy Orton. I'm the Vice President of Clinical Services at the VNA. I want to thank you for your ongoing support of our organization, our patients, and our community. First, I want to give you an update of the programs you've supported, our hospice, home health, and mobile unit. But first, I just wanted to give you an overview year-to-date of where we got to budget. How do I do this? Click.
Technology is a wonderful.
It wasn't me.
When it works.
That was a quick report, Kathy.
I'm glad it wasn't me.
The clicker's not ready. You might have to click.
When you want to go next,
Okay.
see it on the screen, right
Oh,
click,
yeah.
and then go, I know.
Oh, boy. Okay.
Sorry. Or you can tell me to click it for
I'll
you.
do that. Click. Okay, so here we have our budgeted numbers for the fiscal year. You can see our hospice program, we are below budget, and that budgeted number was actually hospice care days. That budget is actually tracking with our overall program. Our hospice program is below budget as a whole, although above budget to last year. Our home health numbers are tracking right on budget, and that budgeted dollar amount is actually intermittent visits. So when we budget for our home health program, it's actually in visits. You can see our healthcare on wheel, our mobile unit is significantly below budget. That variance is not only those patients supported by the taxing district, but the dollar amount or the utilization for the mobile unit is low overall. And we can talk about that more when we go into the individual program descriptions and updates. Okay. Okay. So for our hospice program, as you all know, our hospice program provides end-of-life care for our patients throughout the community in their home, wherever they call their home. We provide care in assisted living facilities, skilled nursing facilities, traditional homes, the hospital, as well as our hospice house. Most of our patients, actually 65% of them, do get their care in the home. And most people want to be in their home when they pass away. Year-to-date, we've admitted over 1,300 patients, and we've seen 6 patients through the taxing district. End-of-life care, we really want to meet the wishes of the patient, help them stay at home. For those patients supported by the taxing district, sometimes that is a little difficult due to lack of resources and support system. Most of the patients that we see through the taxing district do end up passing away at the hospice house surrounding and supported by the staff, which is nice. We recently had a patient that we admitted after he was diagnosed in the emergency room with lung cancer. He wanted to go home. His home was a boarding house. He was a Vietnam vet. His goal, we always ask patients, what's your goal? He said, I want to go home with my friends, live with them, and have the best time I can. So we supported him at the boarding house for about 3 months, but he spent his last 2 weeks at the hospice house. He agreed to go finally, and he passed away with the support of the hospice house. So we thank you for that. What else? So the graph just shows not only different service locations, but the actual different acuity or hospice days. So we provide hospice in different service locations, but there's different levels of care that we provide. So we provided 30 room and board days. So that would be room and board for our patients that we provided care at the hospice house for. And then we have GIP days. That's general inpatient days. So those patients that require a higher level of acuity. So most of our patients can be cared for at the home and managed, but if patients are having symptom issues that need that higher level of acuity and need to go to the hospice house, that's called a general inpatient day. So that would be that. Continuous care is where those patients need a higher level of care, but they're cared for at the home. And routine days, and we hate to call it that because most patients that are terminally ill don't like to say routine, but that's just the routine care at home for our hospice patients. Respite days are what we provide for patients when the caregiver needs a break. So all in all, we provided 218 hospice days under the grant, so thank you for that. Next slide. So hospice, like all healthcare, we need to demonstrate that we're doing a good job. We get lots of thank you cards, lots of kind words, but for healthcare in general, we have to demonstrate our quality as well. And hospice, like the home health, like the hospital, we do have CAP scores, and we do have to publicly report our patient satisfaction, just like the hospital, and also clinical outcomes. So we just have a few of our outcomes here for you to look at. For our would recommend score, our family satisfaction scores, we're at 91% above the Florida and national average. Overall rating of our hospice care, 85%. Again, they're scoring us on a 0 to 10 scale. So for those families that scored us a 9 or a 10, we're at 85%. And then clinical outcomes, did we follow the patient wishes? 99% of the time, families said we did. And did we screen our patients for pain? Again, above the national level. So that's just a little sampling of our outcome scores. That's hospice. Any questions? Okay.
Still always surprises me that the numbers are so low for indigent patients.
The number?
Yeah.
A lot of Medicaid, Medicare.
Okay.
And unfortunately, when we admit them, it's always diagnosed in the ER, so, or from our home health indigent population as well.
Okay.
So maybe not seeking treatment or sad.
Yeah.
When you deal with veterans, do you deal with the VA for reimbursement or attempt to get reimbursed by the VA?
If they have a VA benefit, we do. We didn't have it, yes.
Do you think, this is just since it's coming up, do you think enough of the indigent patients know that it's available to them?
Yes,
Yes?
yes, they do,
Okay.
but they don't necessarily
it's-
take, no, because these people are frightened of everything. And they stay at home a lot of times and just don't seek the care.
Probably education in general.
Education.
I mean, if we look at our hospice length of stay here in this community, it's well below the national average. So we are doing a lot of community education and community education.
I just want to make sure that everybody
No.
that needs it knows that it's available.
The days in hospice can be 6 months of days. Look at the days that people go into hospice.
Our average
Education
length of stay-
that hospice is not, that you're just going to die. It's a way of life, you know, to live every day to the fullest. So it's education.
No, I agree.
Our average length of stay is 34 days, and the national average is probably 70.
Yeah.
And the benefit
We'd
is
li-
6 months.
And I know that the VNA would like to get those days up. It's a matter of education with our referring physicians, and a lot of, you know, a lot of our referrals come right out of the hospital.
So we move into home health, so we can go on a little. So for our home health benefit, we provide intermittent skilled care for patients, usually referred by the hospital or the physician's office. And those intermittent visits are skilled nursing, physical therapy, occupational, speech, home health aide, social worker, nutritionist, so anything needed by the patient to stay at home successfully. So our goal really is on disease self-management, prevent and rehospitalization. Specialty programs, we have palliative care, trying to promote palliative care for a couple of reasons. One, for increase the quality of care, and then to increase awareness and increase that length of stay in our hospice program. Chronic disease management, telehealth program we have, and a new fall prevention program. So we are working to keep those patients out of the hospital. Our average patient age is about 78, and 70% of our patients overall are referred from the hospital setting. But when we look at patients referred to us by the district, the age is significantly lower. Of course, the average age is about 45, and 93% of those patients are referred to us by the hospital. So what does that mean to us? Obviously, they're sicker, more acute, and have had limited access to the healthcare system. So their needs are far greater. Most of the visits, as you can see, when we get these patients, are very nursing focused. About 72% of the visits for these patients are nursing, where our general population, it's about 50% nursing. So much more higher acuity on these patients. A lot of teaching, a lot of disease self-care. We recently took care of a young man for probably about 3 months who lived with his 97-year-old mom, and he too had accessed the ER and was very sick. We saw him 4 times a week for a Pleurax catheter drainage, so we were draining fluid from his lung 4 times a week. And he wanted to stay at home. He wanted to live with his mom, who was 97. He was her caregiver. And we went there 4 times a week to do that and kept him at home. He eventually went to hospice, so he became one of our hospice patients. So not only did we provide care for him in home under the tax and district grant, but also we provided him with hospice services as well under the grant. So much appreciated. Okay. Next. So for our quality scores under home health, we're really quite proud of them. These scores are also publicly reported, and we'll go over them, but these scores are actually translated into star ratings as well, and it's not shown here, but they wanted to make it very transparent for the consumer. So for our patient satisfaction data, we're actually a 5-star agency, so 5 out of 5, just like a 5-star hotel, so we're very proud of that. For our clinical outcomes, we're 4.5 stars. So the average rating throughout the country is 3.5 stars. So we really are proud of the clinical care and our patient satisfaction scores.
Who rates you, please? For
The CMS, so what we have is every Medicare certified home care agency in the country has the same tool. So our patient satisfaction tool and the OASIS data set is the same throughout the country. It's completed by the patient, or the assessment tool is completed by our staff. It's submitted and then goes to CMS. It's a validated tool. And so you can see the patients who rate our care would recommend are above national and state average. And then the hospitalization rates and the emergent care rates are actually pulled from billing reports. So that's separate. And those are two well below the national average.
VNA is the only not-for-profit home health care, right, in Indian River County?
That's true.
Okay, that's what I thought.
Okay. Any questions regarding home health? Okay. So this is our Healthcare on Wheels, our mobile unit, our visit utilization for the year. You can see our total visits throughout the year were just a little over 1,000, and the indigent patients served were at 91. We had projected that we would serve 365 visits to the indigent population for the year, so we are well below budget. So, and well below what we served in the last few years. So that number has been going down over the last few years. I think you're all well aware since January 17, when we changed the process of validating the indigent patient when they presented to the mobile unit. Most of the patients seen on the mobile unit by our nurse practitioners really present with the same low acuity diagnosis that we see for the non-emergent needs in the ER, or the people that are accessing the ER for those low acuity. So we really strongly believe that the mobile unit could help with that ER utilization issue. We are looking to partner and to align with the community providers. We understand we are not a primary care provider, but we really think we have a place along that continuum of care to be that link for the person that does not have a primary care provider or can't get into a primary care provider that day. I know if someone accesses the ER or has a need to meet that day, I think they want it met that day. We recently moved the unit to the VNA Friday and Saturday, and we did a survey for patients, and that presented to the mobile unit, and we got 40 surveys back, and we asked them what they would do if the mobile unit wasn't here today. What would they have done? And 34, 20 of them said they would have went to the ER. So we really think the mobile unit can help divert people from the ER if we can put it in the right place and if we can partner. Our goal is to partner with Vicki, with TCCH, and to really get them to that primary care provider. We're not a primary care provider, but we think we can be a safety net, and we can educate the community. Mm-hmm. It's a lifelong change. It's a culture change for the community, and we can do that.
Yeah, the number, I know the indigent patients
Mm-hmm.
served went, decreased because you're tracking them. Mm-hmm. But what about your total visits that you performed? How does that compare to the last year or two?
It's down about 50% from last year, and like 66% from when the changes occurred. We're trying to change that. We're actually trying to get the word out that we're going back to offering, I hate to say it, free health care. We're partnering with, we met with the Gifford community, we met with Angelia and Freddie, and Tony Brown. We're trying to do a little pilot study with the Sunset Apartments and try to actually see what the needs are within the Gifford community. We had our nurse practitioner meet with some of the residents of the Sunset Apartments, along with Teresa Baxter, to see if we could understand what the needs are and kind of get some trust factor going there. So we've already met with them. We think it's a fairly centralized location. I know we've talked to Anne Marie a little to see really what can we do within the community to help. We're really willing to do anything. We are on the road. We want to utilize it. Our nurse practitioners are there. There's no sense of it sitting there and not.
So other than the other changes that you made when that went into effect, obviously you had to with the indigent, you're doing the eligibility process, but you also put a fee on. You were collecting a fee that you had not been doing before, and that decreased the number that you.
Yeah, there's.
What charge did you?
The fee for a sick visit is $60. Thought that was fairly, a fair fee. But right now, if someone presents to the mobile unit and they can't afford it, they are seen. We do collect if they can pay, but probably about 60% of the patients that present are considered no pay, so they aren't paying. Maybe 30% of the people have paid.
What is the loss in dollars every month? Can you estimate that?
We've lost close to $200,000 on the mobile unit year to date.
Oh, is that all?
That's all. It's an estimate. So it is. That's why.
You also now have your Medicaid. You can the insurance. I think that you did
The
not.
Medicaid, we applied for and received a Medicaid provider number as well as a Medicare provider number. We haven't had any Medicare recipients lining up, but the Medicaid provider number, unfortunately, is a traditional Medicaid provider number. So the majority of the residents in the county belong to Medicare, HMO, or Advantage. So, you would need pre-authorization. So it really hasn't served us well for that. So
Are you
that's.
seeing people come with the card?
We have probably about, I think maybe 6 to 7 patients a month present that are, and then, our billing department does due diligence. We keep a list and they try to go access the portal, and they try to see if people are qualified or, have qualified. So we do bill maybe 6 to 7 patients a month. So there is some billing, but not a lot. So I'm not sure what the barrier is.
I would think that would be climbing the more
Yeah.
cards that we give out, but it's not, you're not.
I don't know. So I don't know if there's a, we've talked about the population or the Ellis population, or I'm not sure who was seeking us out before, but there was, at the peak, we saw about 3,500 visits a year, and now or more.
Are these people that might have had the insurance with the Affordable Care Act, and maybe they've lost that, and now they don't qualify for indigent, and they don't have the money to pay the 60? Because, you're losing quite a bit of money on that bus with these people that need to be seen, but they have nothing.
I think it's probably that, and I do think there is an element of a population that it's difficult to qualify. I mean, we talk about people with mental health issues, and I've reached out to the Source and other places. We have a growing homeless population. It's difficult to get together documentation to qualify. I mean, some people actually don't have documentation to say where they live or who they are, or, so to gather all that together sometimes is not as easy for someone as it may be for you or I, so.
So the bus is actually seeing people that are homeless, that might be living in the
We have, yes.
woods or something.
And those are some of the parts of the community. I've reached out to Tony at the Source and other those communities, and they would actually like the bus to provide services to their
Well,
to them.
of course. Those people are not the healthiest that are staying at those places to begin with.
Yeah.
Out of the three basic things that we require, the district requires for eligibility for reimbursement to basically provide free health care for people, residency, income, and insurance status, which is the hardest thing for them to provide any documentation for? Any experience with that?
I don't know if I can answer that truthfully.
Is there anything we could do to make it easier for you, short of saying we'll treat everybody for free? What's that?
Without documentation, you're saying, yeah.
Yeah,
Go back to being,
So if someone doesn't live at the source or somewhere, do they say, well, I live in the woods is that considered their home? Do you take that down as a residence?
they just, what they do now is they take them as a no pay.
I see.
Yeah.
I see. Okay.
They're not a documented indigent patient, they're a no pay.
We have a way to do homeless patients, though, don't we?
Right,
Yeah, they can-
and so we have a form that is a homeless declaration form that is acceptable in our policy and procedure manual. So to Alan's point is that, that's hard to get, I guess, if you will, because a homeless person is not accompanied probably by someone. And so let's just say a homeless person walks into the bus or walks into one of our providers. They're serving them, I think everyone, the first time, and they're saying the next time they have the homeless declaration forms there, but they have to take that back to their friend in the woods that might write down their name and say, yes, Joe sleeps next to me in the woods. That's my address, right? That's an Indian River County address, and that's a vouching for them. So that's why it's difficult, I guess, to say if you need to show proof that you are homeless. I mean, we do, yes, we have a form, but somebody has to sign that form, and they have to get access to that form, right? So they have to go to their person and ask them. So again, short of just taking anyone who walks onto the bus or walks into the health department or to Treasure Coast and says, or the emergency department for that matter, I guess, and says, this is my status. Yes, I live in Indian River County. Not everyone has a driver's license. Not everyone has an ID. Not everyone has a US or Florida ID. We accept anything with your picture on it, and many times I think the organizations look them up on the website, the sheriff's website, right? It has their picture, so it shows an address and it shows a picture, so that is verification, if you will. I mean, I don't know what the answer is aside of taking their word for it. Anyone who walks on.
I'm interpreting your response as there's nothing we can do to make it easier for you other than just say,
Self-declaration,
yeah.
right?
That was the easiest.
Yeah.
Well, it's definitely the easiest.
No, I'm not saying, the best people to ask would be the people on the bus, truthfully. I don't want to answer that. So, the clerk on the bus or the nurse practitioners may better answer that. My answer would be self-declaration.
We find ourselves in a position of trying to represent the taxpayers'
I know.
scarce resources in a responsible way and wanting to help you serve these patients. So if there's any way we can find a happy medium, that's what we're trying to do. And I think we're all open to ideas.
you know what?
And I appreciate that, so I'm going to ask the people on the mobile unit, because they may have a better idea than me.
Okay.
But I like the conversations that was starting to happen about the collaboration and placing the buses in certain locations where there's need. I think that, I'm hoping that you're going to go further with that.
We certainly
And
will.
come up with a program, rather than going back to what we were doing before. I think there's a great need, and there's certain pockets that, like we just had the discussion with, homeless, it could be, it could be with, Gifford, it could be seniors, it's, there's multitudes, so I hope you continue, and I
Well, I
encourage you
think
to
that was
continue to do that.
the initial, long ago mission of the mobile unit, so we'd like to go there.
Well, I know Anne Marie Soriano also, I think, contacted you about the possibility of being at the Gifford Health Center.
Right.
That's when we found out you were already talking to Tony Brown and Freddie about other places in Gifford. So we would like to continue that conversation, because one of the things that it occurred to us, it's a way to get the Gifford Health Center extended hours, maybe on Saturday morning, for example. And so I endorse what Karen's saying,
And
and
the-
hopefully
Well-
we can keep that dialogue going.
We got invited, or we offered to go to the back-to-school bash at Gifford, August, so we're gonna do physicals for the
Good. With the bus,
bus.
good, because that was pulled away after program funding stopped.
That's
I do think the CEO of VNA, Lundy, is supposed to do a presentation, sort of a strategy at the August meeting, that I think will pull some of this together with the collaborative effort that they have been talking about. So whether, and that will be for the chairman's meeting.
We'll come together.
Yeah.
Any other questions?
Oh, thank you.
Thank you.
Very much.
No, I'd just like
Appreciate
to, I'm sure we all feel the same way. I've had my personal experience, thanks to Anne Marie McChrystal, with the VNA visiting nurses, and you have an outstanding staff
You do.
that do a terrific job. At least they did for my wife. So thank you very much for what you've done, and hospice as well. But
Thank you
Thank
all.
you.
I would echo that, and on a personal level as well. The VNA, I mean, if anybody ever asks me about home health or hospice, or, I mean, the VNA is the ones that I would recommend right now. The people that you hire are so caring. Yeah, they're just really good. So thank you for all of that.
Thank you.
Very nice presentation, Kathy, did a good job.
Thank you, Kathy.
Next, we have the Healthy Start Coalition, Andrea Berry. Welcome.
Hello.
Welcome
Nice
back.
to be in front of you all again. A lot of you all know the history of Healthy Start, but I'd like to start just by giving you all a little refresher. It'll be short. So Healthy Start was created 25 years ago through state statute, and the core of it is to help prevent infant mortality. And how we do that is we assess the data in the community, what's going on that's reflecting and affecting infant mortality, and then increase awareness with partner agencies, funders, families, the community, and then collaborate to create processes that help improve the conditions that are affecting infant mortality. So Indian River County is lucky enough to have one of our own Healthy Start coalitions that works very hard every day to ensure that every baby gets a healthy start. And I'm proud to be the CEO of this organization and proud to have you as partners, so thank you. Okay, so update for 2018. There's a couple of things, and I've given you some handouts, and the second page is a little spreadsheet like this. And the next one is a little colorful chart like this. And that is a new program that has been put into effect statewide called Coordinated Intake and Referral. And it is again, statewide, but basically what this does is kind of solidifies Healthy Start is the starting point, the launch point for every mommy. So whether a mom comes in through the presumptive eligibility process, or whether she comes in for Medicaid, that is, or comes in through our prenatal risk screens or infant risk screens, we have hired a connection specialist. This is a person that is specifically designed to address mama, find out what's going on with her, and then ensure that she's connected to the right program that fits her needs, that hits the needs of the program as well. So we don't want to put someone that has, that's working 72 hours a week with a program that's very intensive that wants to see her every week. That's not going to work out. So not only do we do that, but then the greatest part about this program, and it's implemented into our data system, it circles back with mommy and program, so that the program is then addressing, we did connect with Sylvia, she's doing great, or we did not connect with Sylvia, and then follow back with Sylvia and say, hey Sylvia, that's no problem that did not work out. We are still going to help you. What can we do to get you to whatever you need? So I love this program. I love that we can give a personal touch to it, and I love that we can then do a warm handoff. So we're saying, Sylvia, I'm just making up names here, Kristen call you tonight and talk to you about this program. So it's really giving that extra special warmth handoff, and you guys know I love that. So the next thing is in 2018, we got Nurse-Family Partnership. That will begin in August. I'm so excited about this program. It was identified a few years ago in our CHIP infant mortality work group as a way of addressing infant mortality. And I've put some infant mortality stats in here, and we're going to be concentrating this program in Gifford. And so I have shown this to you all before, but you've seen this chart, this bar graph of infant mortality over the past 6 years. And that is why it is so important that we concentrate on this area. And the other one that I've included for you that's very interesting is this very colorful chart here about infant mortality. And the blue line is the line I want you to concentrate on, which is infant mortality amongst Black infants. And it goes way high, and then it's come down. Now, that might not be the trend that will continue, but I'm celebrating the little things. We had 0 infant mortality in the Black community last year, and that, although it might not be consistent, it's something that we have to celebrate, because that's amazing. That's all those babies that made it to their first birthday. So, and then the last little bit is of stuff I've attached here is about the Nurse-Family Partnership, and I wanted to draw attention to, on that first page, it looks something like this. It's got little babies. It says, emergency department use childhood injuries down 34%. So I know that's not solving the emergency room problem, but it's just a little extra added benefit that we are telling people when it is appropriate to go to the doctor or when it is appropriate to go to the emergency room. And also, this is a more clinical aspect and talking to the whole family. So the nurse is assigned to 25 families in the Gifford area, and she's not just talking to mommy, she's talking to grandma, she's talking to auntie. If auntie has high blood pressure, they're doing the high blood pressure check, they're talking about the high blood pressure, and then they're talking about prevention. Auntie has high blood pressure. You don't want high blood pressure. Let's talk about nutrition. Let's talk about all these things that go into prevention. So love that program. And then to address Babies and Beyond, which is what the program that you all fund currently, our nurse home visit, I just did a couple highlights here, which is we've done 447 visits, and that's 44% of all births at IRMC. I really want to improve that number. We've been working hard to kind of reframe the way we present the visit. In Martin and St. Lucie, you know, they carry this program, and they get a much, much higher, almost 100% of people take this visit because they present it as part of their care. And so working hard to restructure, and granted, ours is brand new, and they've been doing theirs for a very long time, but I still want to try to make it just part of the continuum of care that you're getting. This is just part of what we do here at IRMC. We are going to take care of you all the way into your home. And just a refresher, if you guys don't remember what it was, it's basically we send a nurse into the home within 5 days, check on mommy. We do a well mommy check, well baby check. We do kind of a surroundings check as well to make sure there's nothing alarming in the home. And then we answer all those questions, because when you leave the hospital, if you can reflect back, it is a confusing time. You have a newborn. You've been up all night. You've been through either childbirth or surgery, and you are feeling a little stressed. And you might not be able to absorb all information that's given to you. So we review everything that's going on. So 58% of those that we saw were enrolled in Medicaid or indigent. 43% were exclusively breastfeeding at the time when we saw them. And we want to continue that trend, working with the hospital, become baby friendly, moving forward in our stars. And we're so happy to have that linkage with our hospital that's been so generously moving forward with that baby friendly process, which is going to make us such a shining star on the Treasure Coast to have that baby friendly initiative. And then 97% of mothers and babies were seen in the hospital. So the other statistics I've listed here, indicators, are things that we agreed to report to you when our initial proposal went out. So I just want to highlight a couple of things here. I think that you all know that infant mortality for the 3-year rolling did go up. But I do want to, again, reiterate that we celebrate the little things and that we did have 0 Black infants passed last year, so I'm celebrating that. Low birth weight infants were up a little bit, but I want to say that very low birth weight infants were down. So that's a good thing. We didn't have that on the report, but I wanted to say that to you. Entry into prenatal care in the first trimester went way up. And that is because of the Partners Collaborative. That is because of everyone in this community working together to make that happen. That's over 10% up. That's great. And then low to no prenatal care went down. Smoking was down. Fetal deaths down, and obesity stayed the same. So those are some simple things that I just wanted to go over with you all. And Kristen Crocker, who is our clinical programs director, is here to kind of give you she runs the program, manages the program, and she's going to give you a little bit more intimate look into some of the patients. So thank you.
Good evening. I guess it's evening now. So, as Andrea said, thanks for taking on this program and for helping us keep it going. I wanted to start with just a few remarks from clients that we have. We've just hit our year mark, and we have client satisfaction surveys that over the average, there's several questions, but averaging all that together, I'll just throw out that we have a 98% satisfaction rate. Some of the things that moms have said about the program are, this is a great service for both new and experienced mamas. The nurse was wonderful. She really helped me when I was having problems breastfeeding. She also was concerned about a blood pressure issue, and I'm so grateful because my doctor had to put me on blood pressure medicines. And now I also have an amazing nipple shield, so I can breastfeed my baby. So there's little things. With that as an example, we had, there's not just the failure to thrive infants that are losing weight or the blood pressure issues or the signs of postpartum depression that the nurse is picking up on, and getting them in before that 4 or 6 week postpartum check. But it's also those simple things like the shields and the helping with lactation, because mamas have, I don't know how many of you breastfed. I know a couple of you didn't, but I know that. But
Who are you looking at?
But I will say that it is challenging. And you are, as Andrea said, in the hospital very briefly, and then you take this baby home. And it can be extremely disheartening when you go home and you don't have that bedside lactation help. You don't have someone that's there to cheer you on and support you. So this nurse home visit has proven to help. Our nurse home visitor is also a certified lactation counselor, and so she has lent support to mamas with that. And just even from little things with positioning, moms have been just eternally grateful. With some more comments from some of the clients, she was extremely helpful and reassuring. I think this program is very valuable for mothers and babies. It provides the additional support and can help identify any problems and address concerns early on. It's a great service. They're thanking her for answering all their questions, and multiple people say how just great and wonderful the program is. Just to talk more about the collaboration also, from Healthy Start's perspective, Babies and Beyond, from the health department to the hospital. This program, starting with the prenatal classes, we had one client that I actually met at the Women's Care Center, which I don't know if y'all are familiar with that, but again, another community partner who we have started working very closely with, because they do see a lot of moms, whether it be an unwanted pregnancy or Medicaid or those kind of things. So I do a lot of the classes there, and one of the mamas that I met there, she'll be one of our success stories in the community because she has quite the trauma history. She has a history of anxiety and depression. The father of the baby is bipolar, who also has quite the trauma history. And she started coming to my classes. She was coming to the prenatal classes, came to every one, some of them twice. She had her baby, had a really difficult delivery and time at the hospital, was very thankful to the nurses at the hospital and received great support there. And then followed through with ending up a C-section, if you can say it that way, but she felt, she was frustrated with her experience and having to have a C-section. She went home and had the home visit nurse come out. And one thing that was extremely touching to the home visit nurse and to me as well as is her concern about her mental health history, the father's concern about his mental health history, and here they had this baby and they weren't sure how they were going to be good parents. They didn't think it was possible with their history and what they had survived. They really leaned on the home visit nurse for support and were so appreciative just for her taking the time and her kind words and her reassurance. And then, we're bringing it kind of full circle for them in parenting education and continuing to support them through another Healthy Start program. But, as I was saying, from, whether it be just mental health or postpartum depression, or you have a blood pressure issue or a baby losing weight, or you're overfeeding a baby, or maybe you need a nipple shield. A lot of times you don't know that in that short, brief period when you're in the hospital for 24 hours after delivery. So this program has proven to be very valuable to our 48% of these mamas that we have seen this year. And I, have other mamas that are now recommending it to their friends. And so I think we're going to see that number grow. So I hope we'll have your support so that we can continue it.
I think it's a wonderful program, and what you're doing is great. I have a little concern, and my concern is what happened to Auntie with the blood pressure, because you're not going to be able to take care of her forever. Are we collaborating with the VNA or with TCCH or with the mental health department to help this poor bipolar family? That's what it's all about. You can't possibly do all of that. You've got mamas and babies, so that's what we're trying to talk about right now, is what is the collaborative effort to address these other problems that you identify, because you're there. You've identified.
Absolutely. For the auntie who has high blood pressure, part of the health literacy component of what we do and what we talk about so much is linking them to the appropriate care. So
Right.
So it's not just go see a doctor, but it's
No, it could be the health department, it
Right.
could be TCCH, it could be the bus down the street,
Exactly. But
whatever.
a part of what we're trying to do is be as educated as possible, and this is kind of a process as well about who takes what insurance. This is the type of Medicaid that says you have
Always
this where you
about
can
that.
go, and that is because that's what we kind of have to do to make
I
sure
know.
that, because it is, you can't create a stumbling block. Go see this person, and then they don't get seen. It's not, you cannot do that. That's not what's going to happen.
Right.
So we have to be very on top of things and educated. And I see our health educators going above and beyond to really kind of understand who's taking what and what's going on, so that they don't have that happen.
Right, but that's why it's so important for each one of the agencies to be able to touch base with one another and collaborate.
And also, some of these mamas, for the home visit piece, the beauty of that is we're getting to touch every mom. We're seeing them at the hospital to try and reach out to them, to see them in the home, that may not have come through Healthy Start. They may not have been identified as having any risk, but then when Elaine is going out Because like that mama I was just talking about, I met her at Women's Care Center.
Right.
She wasn't a Healthy Start client. Right. So then, then we got her into services, and not just, I focused on our services, obviously, but,
But you can't do all of that by yourself. So
Right.
you have to touch base with every other organization that has the wherewithal for what you need.
Absolutely, that's an integral part of what we do, it's
Partner.
a collaborative effort, 100%. I couldn't do it without
Right.
these ladies out here, Miranda and Vicky and the hospital and everyone, everyone. We always try to keep contact of what's going on and meet often.
Well, you've been an excellent collaborator with the Partners in Women's Health program.
Thank you.
And last night, I heard a testimony from one young woman who looked like she was about 15, except the baby's now too old for her to have been that, so I have no idea how old she was. But she was saying that her baby was born 2.5 months premature when she was much younger. And that because of the hospital, because of Partners, but also specifically she mentioned because of Healthy Start, that baby's alive and doing well today and is leading a normal, not damaged life. And so it's just one more example of the great work you do.
Thank you so much for sharing that with us.
I have
Thank
a
you.
question for you, Andrea,
Sure,
in that, your enthusiasm and all of your enthusiasm for taking care of babies and mamas just comes through, and every time I see you, you talk about it. How about papas?
That's a good point. We do. We talk about, so much of what we do, and I catch myself with this a lot, but so much of what we do is when baby's in belly. So we're talking a lot about that, but that is something I put on my service delivery plan to look at for next year, concentrating on it. In Martin County, they have a fatherhood initiative program, and I really want to look into that to try to develop that locally. We have talked about some initiatives educating younger boys about parenthood and even breastfeeding and everything to kind of try to normalize that stage in life. Like, you are going to be a daddy at some point, probably, and these are the things that you're going to experience. So we've been batting those ideas around with partner agencies to see where they go, but I've definitely been digging into the Martin County model a little bit to see how it worked for them and what effects they've had, what outcomes. And that's the problem, is I don't think that they've had substantial evidence-based consistent outcomes. So I have to kind of do a little bit more digging.
You just gotta believe that if there is a family unit, and you can get the whole family unit comfortable with this little baby that you've got and sharing. I think because a lot of men, and particularly if they're very young, okay, and all of a sudden have that, they really shy away from that kind of responsibility. It's scary. You don't hold the little baby like that, and that kind of thing. But I think that education is just...
It's the responsibility of something like that that's overwhelming for young men.
Absolutely.
They're not even men yet.
Right, and it's hard for a young mother as well. So
Right.
Our programs do, parents as teachers and healthy families, they work with the whole family.
the classes too.
And the classes too, and Kristen's classes.
We do have a lot of couples, the
Okay.
father of the babies do.
Who does that now?
Our prenatal education
Right.
classes
Right.
that Kristen hosts oftentimes she doesn't just have the daddy, she's got the grandma and the grandpa and the uncles and the aunts and everyone in there.
And I've started having just dads come.
Oh,
That's
that's
good.
great.
That's
Had
good.
two
You
where
have
just the dad-
an average of the ages that you're serving.
We do.
Because I think that's very important
I would
as well.
yeah, we keep that on.
I think that's very important.
I would be happy to send that to
The
you.
younger that, that they're just so unprepared for that kind of responsibility. And
She has it. Do you guys want to,
Yeah.
okay, go ahead.
Well, do you want for the year or quarter? How do you want it broken
The
down?
year, just do the year.
Oh, goodness, then I have to do math.
Okay, just.
Hang on.
No, just give us the simplest order.
Whatever is
Well,
evident.
it's a small number here. Let's see.
I think that's the number together, isn't it?
I didn't,
The largest amount, so if you go percentage-wise, if I just break it down, you know, what is that percentage? 11 out of 471. I don't have percentages. I've got,
That's 15 to 18, so 11 of the mommies were.
are 15 to 18 years of age?
Out of 400 and,
out of 471. That's in the past, you know,
No,
6
about
months.
6%.
That's only 6 months of data. And then I've got about 130 that are in the 19 to 25 range, 130 out of the 471. Sorry, I don't have the statistics.
Do you have the age of the father? No, but that would be interesting to know too,
I would
because
like,
that's very difficult.
it is. I would like to, that's good. I like that.
Yeah, okay.
Father info, father info. Taking that down as a note.
Okay.
Is there anything else, you guys?
Any other comments, questions?
Just thank you.
Thank you, it was a very
Thank
good
you.
presentation.
So much, guys. We really appreciate your
Yeah.
partnership and support.
Good luck with everything.
Thank you. Any unfinished business from the trustees? Not anymore. Okay,
This is unimportant.
action required, approval of the tentative budget. Alan?
Okay, as you know, we've discussed this for some time, but for edification, you have before you our proposed budget for the 2018-19 year. Today, we need to vote to approve or modify this budget. Excuse me. Whatever we vote on today, however, is important to underscore that that'll be the maximum that the budget can be. So in September, after a due amount of public comment and response, and in our particular case, consideration of what's going to happen with IRMC and Cleveland Clinic and everything that's sort of in a state of limbo, there's a lot of uncertainty with where we are. So this budget, as is presented, would represent a millage rate of 0.9405. So I would point out that the biggest amount of increase in this is for IRMC. A $1.2 million increase over what was budgeted a year ago. And if RMC, so that's a total of $7.5 million for RMC for indigent care. That's in this budget approximately. If that turns out to be $5 million, this millage rate falls to 0.78. And if that turns out to be less than that, then it falls even further. So that's the reason that we have what we have. I guess I'll make a motion that we approve this budget as prepared and open it up for discussion, assuming I can get a second.
Second.
Sounds like Barbara wants to make a comment.
Is there any, okay, we've had a second. Comments from trustees?
I'll make a comment, as I usually do. There has been a property property value increase, and if you keep the millage rate the same as it was this year at the 0.8894, we still would be getting almost $1 million over the amount of money that we got this year, and I think we can live within those means. So that's why I would not vote in favor of the 0.9405.
Other comments?
Oh, I'm also, I have a concern about the $7 million for the hospital. What, if we do this, we approve it, and then we don't need it, how are we gonna handle that? We've already collected the money in taxes, so the taxpayers already felt the bite. I'm just a little concerned that perhaps we should keep it maybe $1 million less, more along with Tracy's figuring, and we would still be within a comfort zone on that.
I am,
Because I'm pretty sure that we're going to go through with unless something radical happens with the Cleveland Clinic in the very near future.
I do believe that we will have enough definition on where we're going before the September vote to be able to adjust it.
I agree.
We'll
Again,
have that
it has to
definition.
be mentioned that this is the highest.
Yeah, this
and
is the highest.
We have 2 other meetings that we can lower it if
Right.
necessary.
Knowing that we could go all the way up to 5 as a millage rate.
Also, I wanted to clarify the IRMC thing. Yes, it is 1.2 million over what we budgeted last year, but it is pretty much the same of what they will spend this year.
Glad you said that.
Right.
I should have said that.
Exactly.
So it isn't like they're asking for something
Yeah.
that they didn't spend for, so I wanted to make that note.
Well.
Barbara, do you have any comments?
I do. For the little bit that I can hear, as far as the approval today, I feel that millage rate is a bit high. However, I understand that we still have time to work on it. And from the meeting that I listened to on July 11th, I feel that we are going to work on some of those. So, as much as I don't like 0.94, I'm gonna be okay with it until we have further talks.
Any other
Okay.
comments? Okay, can we take a vote then to pass this at the .9405?
It's an I guess it's an
What?
Before we vote, we need the public comment.
Yes, we can have public comment.
Val Zudans. I obviously agree with my wife, but what I was going to say was...
Good move.
So one thing, I looked it up on my source was CNN, so I don't know if we can believe it, but it said that regarding the ACA decrease, there's about 3.8% decrease last year. So unless Indian River County was a significant outlier, there's not a big decrease in ACA enrollment. So going back to, it goes back to what happened this year to increase the spending at Indian River, and is this a one-off? And I think there is something that happened this year that we talked about last year with the budget that was a one-off, and that was there was a huge backlog, and there was a whole bunch of patients who got expensive surgical care and other things in the hospital this year that once you clear those lists, we talked about that it probably would not be a recurring cost. The second comment I have is that $980,000 is what, somewhere around there is what you're going to get just from the increase in property values. You also set aside $1 million last year and spent so far $700,000 plus of that, and you're probably going to spend the rest. But you're not going to have that same $1 million cost next year. And initially, I guess it was budgeted for a couple $100,000. So that's like, or maybe it's $300,000. I don't know what it's going to be, but there's probably another $700,000 in cost savings. So we're talking about $1.7 million, and to justify raising the tax rates when everyone else I've heard, I'm on Vero Beach City Council, we're not raising tax rates. I've heard the county's not. I've heard Sebastian's going to be cutting maybe all the way back to their rollback rates because they're all getting a large increase in money. So I think that the hospital district will look as an outlier if you're doing this, and I think it's totally unnecessary. You're going to have, now unless there's going to be a lot of spending on new programs, which...
There you go.
Yeah. So the question is that what you guys are planning on doing? Are you planning on spending, and starting a whole bunch of new programs, or are you planning on being, looking really carefully at the taxpayer issue here?
I think we're looking more at what the needs are in the community for health care, equitable health care for people that don't have the means to walk into a doctor's office and pay the fee to be seen. And I think we're addressing that. I think we had a robust discussion about it today at the chairman's meeting. There are issues out there that need to be addressed. We talk about the Alice population. It's above and beyond, of course, the indigent population at 150% or whatever. But there are needs out there. And so dependent upon what is going to happen with the Cleveland Clinic situation and what they might absorb or not absorb, there's going to be more. There are more people coming into town, and there are more people that are going to have needs, and we're trying to address those. We're making that a mission of this district, a purposeful mission to address the situation out there. It's out there. These people need care. Whether we decide to program it or not is something that this district has to decide. So to cut it just to worry, I mean, you saw what the chairman of the county commission said. People don't ask about the tax. They want their roads fixed. They want the bridge cleaned. 17th Street Bridge, you know, remember that one? And the lights and all the rest. They want that done. They don't ask so much about their taxes. But the people that are out there that need the care, need the care. And we're just trying to address what is equitable.
Well, and along those lines, I am on Vero Beach City Council, and our ad valorem taxes are less than half of what the total amount that this hospital district is collecting from the taxpayers. It's because you have a county-wide tax base. Our rate is higher, but the total amount is
Right, you're just city.
in ad valorem taxes is a lot less. And so I'm just saying that you guys, I'm encouraging you to try and live within the extra $1 million that you're getting, and the reduced cost from not having to do the partnership process again this year. That's like probably $1.7 million, somewhere in that range. I don't understand why you guys can't figure out a way to do set the priorities right and take care of the indigent and do the necessary programs to improve the health without raising our taxes at the same time.
I will say in regards to the commissioner's statement and nobody asking for lower taxes, I don't think anybody asks for their taxes to be raised either.
I agree with that, but nobody asked for them to be lowered where somebody might not be getting care. And I appreciate what you're saying, Dr. Zudance, but I think that when you look at what's out there and what needs to be done, and the people, even in the We Care program, that aren't getting further care beyond the initial being seen and diagnosed, all of that needs to be addressed. Those people haven't been able to get follow-up care. Where is that going to come from? And who's going to pay for that? So I just think there's a lot out there, and we're not raising it that much, and it isn't even a decided thing until the very end.
I would say that there are several areas where we know we will have more definition over the next 2 months before we vote on the final. Last year, this is not untypical of what we do, and then generally it comes down as we get more definition. We will have more definition on the hospital and Cleveland Clinic. We will have more definition on the VNA project that they are proposing that is included in here. We'll have more definition on a number of those things. So, and we will also have more definition on where we're going with the Gifford Health Center and some of the added things that we're talking
We'll
about.
have a little bit more information, you know.
So I'm confident that this group will do their due diligence to make sure that we're spending them at the right level.
Well, we have that information on time because we have to make a decision by September. And I want to point something out, which it seems to me that there's some kind of fetish in what the mill rate is. And I think that's overblown. The mill rate is not what's relevant. What's relevant here is the amount of money that we're raising. And do we really need to raise this much money at this point in time? Because I think there is surplus in this budget, and we should look at that very carefully because, pardon me, I don't particularly think the comment from the county commissioner that, oh, people don't mind paying taxes, just ask them. I think there are a lot of people who are working people in this community who may be in the Alice group, who own a home, who are taxpayers, and are just squeaking by. And when we say, well, it's only a few dollars to us could be a lot of money to somebody else. It depends completely on where you are and in the economic scheme of things. And I think it's important that we realize that when we say, you know, it's a small amount that you're raising tax, that for some people this could be very significant. And some of these people, in essence, you're asking them to pay more taxes to provide, in many cases, services that they can't afford themselves and that they're not eligible for because they fall beyond the limits that we have placed on eligibility. And I think we should think about those people in particular. I think they're important, and we have to bear them in mind.
Well, it's hard to argue with any of that. And I think we'll end up doing that by the end of September. I would point out, Mary Beth said that we're talking about trying to reestablish the, or as Miranda calls it, restore the Gifford Health Center. Right now, the Gifford Health Center has 3 people in it. The district took taxpayer dollars back in 2003 and spent $2.6 million, supplemented it with $400,000 of charitable donations, and built a $3 million facility in the middle of Gifford for a specific purpose, to improve the health care in Gifford. Right now, there's 3 people there, 3 clinicians, and 3 support staff. Now, there's a long story as to why that's happened, but we've taken a look at that, and we've added $500,000 in money we didn't spend in the past to do that.
Well,
The VNA has come up with $292,000 that we don't even fully understand. Now, we could cut that out because we don't understand it, and it would make better press maybe on what the millage rate is. But I think the wiser thing is that we know we're not going to end up at 0.94. I mean, we know it. But we got to have it there in case something happens and Cleveland Clinic doesn't happen. What are we going to do with IRMC then? We're going to have to relook at everything when that happens, if that happens. I don't think it's going to happen. You don't think it's going to happen. But right now, we don't even have to take the risk that it doesn't happen. We just approve it as is, and we'll whittle it down over the next 60 days. And as I said, even if the hospital portion were to drop just a third, it would take the millage rate down to 0.78, just that. So we got a lot of work left to do. This is not intended to be the final budget, and I hope it won't be reported that way. But it is where we're going to start unless we disapprove it. So enough of my comments.
I just would like to point out one thing. There's more than the 3 people at the Gifford Health Center. There is a physician there on a part of so many days, I think 3 or 4 days a week from We Care.
You're right.
Seeing people. So it is being utilized. It is still underutilized quite a bit, and we really have to get more into that community. And
Healthy Start has just moved 6 people in there.
So yes,
things are changing. The point is, it's an underutilized facility that taxpayer dollars funded. And it's our responsibility to the taxpayer to be sure that doesn't become wasted.
That's right. And that's just one part of our county.
That's correct.
Focus.
That's correct.
We have the rest.
Okay.
Any other comment? Then I would like to take a vote. So all in favor?
Aye.
Can we go down?
Yeah, do it one by one.
Okay, let's do it one by one. Tracy?
Nay.
Sharon?
Nay.
Michael? I'm a yay.
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 Barbara?
Yay.
Okay, thank you again. I just needed to hear you again. All right, thank you. So that does pass 5-2. We do have one other issue that we wanted to bring up to the district today. It has to do with the hospital. We did talk about this a little bit, but the parcel property split up, and looking for approval from the trustees in order to be able to go forward to do that. So Anne Marie, do you want to go through that?
Yes, I think in your package you have a little map of the entire parcel of the hospital campus, I guess, the parcel that the hospital sits on. Also, that is all in one parcel number, one tax bill, if you will, with the county. And on that parcel sits a piece of land that is owned by the district that the hospice house sits on, and some vacant property in front of the hospice house all the way out to 37th Street. That's denoted on that map as parcel number 3. That piece is not included in the land piece of that, will not be included in the lease, is not included with the hospital lease, although the hospital over time has maintained and paid expenses on the front part of that property, and the VNA, we have a lease with, this district has a lease with the VNA for the land that sits under the hospice house. So the other piece of that entire parcel is the land that the Human Services building sits on. The district owns that Human Services building, and that building is leased for use to the VNA as well. The piece of property that extends from the VNA building, the HSB building, out to Huma Crystal Drive would be all included in parcel 2. Parcel 3 would be making this entire one parcel 3 parcels. It's very confusing, but the point is, and I did check with Gray Robinson, they are the ones recommending that we do this. They've had survey work done by Carter and Associates. They have spoken to Cleveland Clinic or have been in conversation with Cleveland Clinic, so Cleveland Clinic is very aware that this could be, or upon your approval, would be 3 separate parcels, and what they would be leasing from the district in the lease would be the parcels, the remainder of the parcel exclusive of 3 and 2 as we've divide them. So all this is
Just cleans up what actually we've been doing.
right, cleaning it up, making it a little more user-friendly for the hospital district, obviously, as we look at those other pieces.
And you said that in the case of parcel 3, the hospital has been taking care of the land?
At one point in time, they have, we currently, today, the district cares for the piece of grass out front of the hospice house.
So we have somebody cutting and we're
So we have
paying
somebody
for it?
cutting that we are paying for
Already,
now.
okay.
That's already in your monthly expenses.
Okay,
So,
fine, thank
so it really is a cleanup of division of what the district cares for and leases separately to others than the hospital now. A couple things I will mention that, and if I read this, it's just because I want to make sure that it's clear for all of you to, from Gray Robinson, that they think are important and why they're recommending that this split happens. Now that there are assessments which are applicable to both parcels for county landfill fees that will probably come with this split that the district will be responsible for paying for. I already mentioned in the past the hospital paid the bills on the other piece, and we may get pushback to that in the future for Cleveland Clinic not wanting to pay for expenses unrelated to the piece that they are leasing on our behalf. The VNA Human Services building in this split will not have frontage onto a public highway. It comes on the frontage road, if you will, the Huma Crystal Drive road, so it doesn't come straight off. There's no access to that parcel from US 1 or from 37th Street, so there will be easements necessary at some point in time if anything different than what's happening today happens to that piece of land, sale of that piece of property or some other tenant or some other lease. Right. So that would have to be in there. So I just mentioned those things so that you're aware of those, and that in the future, you know, there will need to be attention to those pieces of property that would be outside of what Cleveland Clinic would be operating, if you will. So Unless there are other questions, you would need
I-
motion to
Is that
approve
clear
for
to
me to
everybody?
sign off on the lot split so that they can submit it to the county.
I'll ask for public comment before we have a vote on that.
Have to have a motion in a second first.
Do I have a motion?
I make the motion. to do this.
I'll second.
Okay. Any public comment related to this? Okay, I'd like to take a vote then. All in favor?
Aye.
Aye.
Any negative?
Aye.
No negative. Okay,
Excellent.
that passes then.
Thank you.
Any other business from a trustee perspective? Any other public comment? All right, thank you very much. Appreciate you all being here tonight.
Bye, Barb. Thank you.